Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is CMO's CEO, Dr. Joshua Liu. Today, we're joined by Dr. Adam Carewe, co-founder of NerdMDs, creator of TechDad CO, and former CMIO at the Colorado Permanente Medical Group. Dr. Carewe, Adam, welcome to the show.
Thanks, you guys. Happy to be here.
Yeah, it's so awesome to have you on. Many of our listeners know you have your own podcast and you're so well-versed in all of the topics that we talk about. And so we're so grateful to have you on the show today. This conversation really wouldn't be possible without social media. So I just got to give a shout out to social media and LinkedIn, to be frank. I know Josh had posted a question on there asking about the sticking power of Ambient Scribes and the idea that maybe the most expensive Ambient Scribes are potentially the easiest ones to buy right now. And we were curious, will that change with time? What's the sticking power of these technologies? So A, just a shout out. That's really cool that we can make this happen today. But B, we're super excited to dive deep into this topic with you. But before we get there, I do want to kind of bring up the conversation of understanding how you got into healthcare in the first place and what drew you to technology and informatics to begin with.
Yeah, no, it was a good question. And I do like sharing this because I think it's an interesting kind of career arc. I've always been involved in technology. I mean, as a young kid, I always shared my grandfather was the one that actually introduced me to it. Every time we would go to their house, they live close to us, he would always have like some sort of gadget, and you got to think this was like in the 80s. So like the gadgets back then were like the things that the kids have in Stranger Things, like the giant walkie-talkies. My brother and I had those. So that was kind of what I was kind of growing up around. And so I think I always liked that. And I thought it was cool to go to my grandpa's house and, see what he had, back in his den. And he'd always share it with me. And then he'd usually say, hey, why don't you and your brother take this home? You guys can play with this. I think he honestly just liked to buy things and then give them to us because he knew we would have more fun. So I think all along I had that as a base. And then when I went to college, I didn't start in medicine. I thought I was going to be a teacher coach, and I really liked math. I played basketball in college too. So, I had this sports piece to my life. And, as college started winding down, I ended up majoring in kinesiology, which is like the study of human motion and science. So I was like, and again, it was kind of a selfish reason. I wanted to make myself a better athlete. So why not study something in college that can actually make you have better nutrition and performance? So I went to graduate school at San Diego State after that for exercise physiology. And it was during that stint, I did an internship in cardiac rehab. And cardiac rehab was my initial step into the medicine world because it was at a hospital. And we did a combination of, we had an offsite facility where all the patients would come and actually do the rehab after a heart attack or a heart surgery. But we also would go in the hospital and we would do bedside education, rounding, which I didn't know it was called rounding back then, but we did. We'd have a list and we'd go to the appropriate patients and I would just teach them, what they were, how their life was going to change and what they needed to do to be heart healthy, from here on out. So I had a mentor there that just asked me one day I did an internship as part of my master's degree, and I didn't think it was unpaid, which I don't know how I did that the whole summer in San Diego. But my mentor there, Mary, she's retired now, and I'm still in contact with her on social media, like you said. And, she just asked me, she's like, what do you want to do? And I was like, I don't know. I like this. This seems cool in the moment. And she's like, well, have you ever thought about being, a physician assistant, nurse practitioner, or a physician? And I was like, never thought of it. And meanwhile, in this experience, I got to scrub in for an open heart surgery. I got to see these things. And I always thought they were cool. But, she was just like, you should think about doing that. She's like, I think you'll be really good at it. And I was like, okay. No one in my family was a doctor. My sister, I think, had just recently married someone that was in med school. So I at least had that. But that is kind of what shifted me to do it. And so then I had to go back and take a bunch of undergrad classes because I didn't have all the science that I needed to get into medical school from my undergrad degree. But yeah, it's just even in medical school, I would volunteer for, committees, and then they'd be like, okay, what do you want to do? And I was like, well, is there a technology piece to this committee? Do we need a website? Do you need to make digital flyers? I kind of self-taught myself, and I took some classes on web design and graphic design. So I kind of learned how to do that stuff. And, like NerdMD's logo, I made that myself. Like I didn't hire someone. And so I think it's just all along, I was always interested in the technology side of everything. And as I got more and more into healthcare, again, preaching to the choir here, but like, I just saw more and more like why is the technology so clunky? And why was it so hard when I would go to a new hospital and have to like use this different system? And it was similar, but different. And so I just really became interested in, making those things better, ideally for myself, but then like obviously for physicians and ultimately everyone else that's taking care of patients. So I kind of naturally rolled into informatics, not knowing that that's actually what it was. And, it just continued in residency. And then when I joined Kaiser, I met someone and they were like, hey, we have this team, you should apply. And so I applied and it just kind of snowballed uphill, and I created more things, tried to learn what pain points were and ultimately landed in the CMIO position.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more.
Alan, I had a very similar kind of backstory for our getting into tech. So for me, as a kid, I was like building websites and learning how to use Photoshop. And it was just like, I think I've just always enjoyed creating stuff. I think, Alan, you're probably pretty similar, right?
Always. Yep. Tech from, an early age. I remember I think I put a piece of bread in the VCR when I was like 2 years old. And ever since then, I was just like attached to tech, hopefully for the right purpose. But yeah.
That's funny.
I mean, I feel like it's the same thing now we do, right? I mean, now like the next like GPT thing that comes out, or I find out about, this new notebook LM thing from Google, like I immediately went and started playing around with it. And I was like, this is crazy. Like, I love to like tinker in those things and then try to figure out how that tinkering can turn into something bigger.
Do you find that's harder in healthcare? Because I feel like in most other companies or industries, you can tinker more quickly or easily with new technology, but in healthcare, because of either regulatory or patient safety, you just can't get it to production as quickly. Has that been an issue from your perspective?
Yeah, I mean, it definitely is. I mean, I think like those, especially the things you want to, really push the envelope with in the tinkering space, I'd say, or like the skunk work space. I think like inside a healthcare system, it's much more like you just have to find your way that you can kind of fit what you honestly want to do and what the organization needs and what you can do within the confines of, the resources and finances. And I think it's funny. I think some of this probably was to my advantage when I started because I was young and I was like new to being a doctor and I was somewhat naive. So I wasn't afraid to like ask for things. I think as I got more involved, you do kind of become more shy in a way to like ask hey, can we get some funding for this? Like, what do you think about this idea? Back then, I would just be like, oh, I don't think we do enough, education for our physicians in our group on how to use the EHR the best. And I said, how come we don't do that? And people were like, well, we've never done that before. Like, we don't have a program for that. And I was like, well, can I do it? And they're like, sure. And so I started like a computer-based program where it was like in a computer lab, and physicians and advanced practitioners would come in. And then I just started going around I contacted all the chiefs of all the different departments. And I just said, hey, I'm in this new role. I can come to your department meetings, find out your pain points, and maybe give you 5 to 10 minutes of like kind of quick tips that can apply to your specialty. And I didn't know how to practice, head and neck surgery, but I knew enough to listen to what they would say. And I could quickly be like, oh, they would benefit from making this tool, for themselves, or utilizing this feature. And that type of stuff just snowballed over time and got more programmatic and better. And I think that's where, like most things in life, if you just kind of like keep grinding at things, people will notice, and then they want you to do more.
Awesome. So I wanted to ask you about, I guess, the original reason we ended up doing this podcast. And so I, as Alan mentioned, I'd posted this question on LinkedIn about Ambient, and the context for the listeners is, I've talked to, quite a few CMIOs and CIOs over the past year about how they're choosing their Ambient partner. And I think we're finding that it's probably the most adopted one, whether it's, frankly, it's probably not the most publicized in terms of adoption, but I think Nuance, the incumbent with Dax Copilot, it feels like has been the most widely adopted so far, despite, I think, a lot of folks telling us it's the most expensive. It's kind of what we've heard from CMIOs.
Yeah.
And then when I asked, well, then why is that still the most adopted one? And often it's things like it's easier to buy. If you already have a Microsoft or an Azure contract, it's easier to add it on, or it's a known entity. It's less risky for us to buy that, at least from putting my name out their point of view in my organization. I'm kind of curious if that's the same thing that you're hearing from your colleagues. And then also, does that really have staying power then, if it's purely because it's just logistically easier? How long is that advantage going to last? I think it goes back to, there's this common phrase of, well, startups get distribution before incumbents get innovation. So I'm curious kind of how you're seeing it play out so far, and where it might go.
Yeah, no, it's a super good question. And I do remember when you posted that, and I do remember my response, because, in some ways, I don't think it's fair. I'll just throw that out there. And I think, what you explained, it's should just the behemoth, kind of get the advantage for whatever. And I'm not saying anything, that's not meaning to be a negative comment towards Microsoft or Nuance. I use plenty of their products, and I have plenty of friends that actually work for both of those companies. So I think they're doing great, but I'd phrase it this way. I think there's a misconception out there. If we move on from just kind of the Nuance part, just having that kind of framework already established in a lot of health systems. The second layer was really who Epic chose to be their kind of development partners, right? So that was also Nuance, but also Microsoft in even grander fashion for more of their things that they're doing. And then it was also with the Bridge. And, you could argue, people were like, well, who's this a Bridge? Just a little over a year ago when Epic announced that. And I think again, I love the people at a Bridge too. I know I've got to know them obviously very well and know several of them personally, but I think in some ways it was also an unfair advantage that they were given. It was fortunate for them, but kind of unfortunate for a lot of the other companies that were also developing kind of very similar products and strategies. And it just kind of, I've heard it many times from, frankly, CMIOs. They'll be like, oh, but, we didn't try and choose, we can name some names. I guess we could say Nabla, Heidi, some of these other ones, Ambients that are out there. And, people would say, oh, we didn't look at those because they don't integrate into Epic. And you're like, literally, and I think this is worth clearing up for everyone. The agreement and the partnership that Epic has with Abridge and Nuance are just development partners to create the APIs. So essentially, if you go with one of those partners, which is totally fine if you do, but if you do, you're basically getting a 3 to 6 month lead from when all the companies will have access to the exact same APIs to make their product fully integrated into Haiku and Hyperspace. And I've heard tons of CMIOs that don't understand that. And so I think there's like a misconception out there of it too. But yeah, so long-winded way of starting with like what you asked, Josh, with like the costs and everything. But I think frankly, there's a lot out there that are a lot more cost effective. And you could argue right now, there's several of them that might even be better than those two, like truly from a usable standpoint, from a personalization standpoint, from those aspects, which you don't really hear that much, in the LinkedIn sphere.
Well, maybe to unpack that a bit more, putting your CMIO hat on, do you feel like there truly is real differentiation that can be achieved on the ambient side? Because I feel like a lot of folks think it's pretty commoditized or it's getting there. So if you're the CMIO and you're kind of leading an evaluation, like how are you thinking about true differentiation? So that way, maybe it's not just all about price at the end.
Yeah, it's a good question. I mean, it's kind of my approach with like almost generally with any vendor. If you're looking at a group of vendors that are kind of helping to solve a problem that you are trying to look to solve in your situation. I mean, for me, there's like big buckets that you always want to look at. I mean, I want to look at the people that are running the product, because I think that makes a big, huge difference. Because I know you've commented and said a lot of this type of stuff, Josh, I've heard in the past too, where it's not just about the implementation, it's about the ongoing relationship that you have. So I really look at that now a lot, or I was in my previous role quite a bit. And then I think the other thing that I try and get into kind of, which I would consider like the next level of like a CMIO evaluation, is I want these companies to tell me what they're doing next. Like not even just like in the next 6 months. Like, I don't want them to give me like a trade secret or something, but like, I want to know what they're going to be doing in that future, because that's the one where you can get some more insight in. Because I think, to your point right now, a clinician can pick up, honestly, any of the ambient scribes, and it can be pretty darn good right now. But I think what's going to change over time is it's instead of just being this kind of lumped kind of note that's generated that then you can either copy pieces and parts or all of it in block. I think like what's going to happen is we're going to take that ambient encounter and discussion, and there might be a note that's generated, but I think it's going to pull more of the discrete information from that conversation and ideally just start to file it away. So in a way, like the note could actually kind of go away. And so I think like that's where these companies need to be developing to, because really all we've created now is like really just an AI scribe. And I think most of the companies hate it when you call them an AI scribe, because I think they want to be more than that. But I don't know. That's how I would answer that.
Do you have any thoughts as to why, like, because Alan, we've kind of been looking at the announcements from Epic, and you were at UGM recently, Adam, and there's over 100 or so different AI projects Epic has been, working on with health systems. And the actual scribing part is like the one piece that it chose not to do. And it's almost like all the innovation after that, like once the data is in the HR, they want to do all the other AI stuff with it. But the actual scribing part, they didn't really want to do yet on their own. Do you have any thoughts as to why that was the one piece they chose to, let's call it, partner with any other outside company?
Yeah, another good question. I guess I would actually answer it slightly different than what you just, like the way you asked that, in that Epic's actually doing very little of their own like native like AI build. I mean, they've always had some like machine learning things that they've worked on, from like the way InBasket gets kind of like pre-sorted and things like that. They've done that for a while. And they obviously have some other kind of, algorithmic type things, like sepsis predictions and things like that. But like, yeah, when they actually, so for Gen AI, Epic's actually not doing any of that in-house. And I think it's actually smart. I mean, so what I would frame when Epic says they're working on the 150, things, well, the way I interpret that is they're creating the fabric and the framework inside Epic, so those things can be plugged in to an existing technology, usually an LLM. And I think even for the ambient piece too, they're really just plugging in those ambient pieces to their existing framework. And because I think what they're planning on is that this technology is going to continue to just get infinitely better. And frankly, companies like OpenAI and Anthropic and Google are probably going to be the leaders, and probably Apple will probably catch up at one point too, and maybe even surpass, you never know. But I think those models or some future medical model will come about, and Epic will already be ready to basically like pull the plug and put the new plug in, you know, and as a feature, it'll feel the same, but as the experience and the accuracy and the precision of it will just get infinitely better. So that's what I think is coming. And I think that's the approach. Again, I don't have inside knowledge of Epic, but that's at least what I think what their approach is. And I think it's super smart because it's tough to maintain that kind of crazy, you know, magical kind of technology, you know, that's literally just getting better every month.
That's true. It's almost like they should focus on their core competencies and their core business model, and everything else that can be done better by, like you said, by OpenAI or one of the other companies. Let them lead that.
And that part is like very, very new for Epic. I mean, like Epic they've never acquired a company, right? They say that at every UGM. But I think the difference is, and, you know, Brandon Keeler's mentioned this, so I know it's actually true, but Epic, like these companies they're working with now, they do get kind of like an equity stake in them. So they are partnering really for the first time. Before it was less of like this direct kind of partnership.
It's true. So definitely is a change there in how intimately they're going to be working partners going forward. That's really interesting. I wanted to ask you a little bit about the Kaiser experience. There's the whole thing with NAMBLA and Abridge, and don't know how much you can actually comment, but I think it's actually a really good lesson for, you know, healthcare startups, because I don't think a lot of them fully understand what actually happened there. I think folks were confused that they thought NAMBLA was probably deployed across all of Kaiser. That wasn't technically the case. There was actually more going on with Ambient beyond NAMBLA. So anything you can share about the story, what folks should actually learn from it?
Yeah, and I think like it's probably important to even like zoom out a little further and just so people understand how actually Kaiser works, which I don't think many people know this. So Kaiser as a health plan is national, right? And there's markets that have the care delivery part of it. But I mean, as a Kaiser member, I can go to Alaska if I had Kaiser insurance, and if I got hurt, I could go see someone. I wouldn't see a Kaiser person, but I would be able to, you know, get taken care of. But in each of the markets themselves, every market has their own medical group. So it's a separate company. That company, the medical group, like I worked for, you know, Colorado Permanente, we were in an agreement with Kaiser Health Plan and hospitals to basically serve the Kaiser patients in that region. And so what has happened, you know, some of these medical groups are large. I mean, Colorado Permanente was like, you know, we have about 1,200, 1,300 doctors. The medical groups in Northern and Southern California are huge. Like, I mean, 10 times as many, 10,000, you know, 11,000. I actually know exactly what they are, but I think it's around that. So with those medical groups of that size, like they essentially, I mean, they have some of their own kind of technology shops inside of them, just by the nature of it. And Kaiser still has their own IT shop, obviously, that also is kind of centralized but regionalized. And then, so in this case, you know, I think really what this was the medical group in Northern California wanted to really jump on quickly to the Ambient, you know, experience and get their physicians to start using it. And this happens a lot in many of the medical groups. The medical groups will actually fund something before the Kaiser enterprise can get behind it, because it just takes longer. There's just more kind of bureaucratic process layers. And so that's all that happened here is just, it was Northern California's medical group called TPMG. They were the ones that partnered with NAMBLA for this contract. And then as that contract was in flight, and again, all of us were very jealous outside of Northern California because they were able to start using one of these right away. Then Kaiser quickly in hyperdrive, you know, really got an enterprise process together to look at all the different players and do a much more, I'll just say it was a very, very rigorous process that Kaiser put all of these vendors through, and particularly Abridge, you know, who finally ended up getting the contract. But so that's why it looked like Kaiser made this pivot switch, but it really wasn't a pivot switch. It was honestly just TPMG being really early adopters and wanting to try something, and they published stuff. So it's like they did some great, you know, for the community too, the greater community by doing that.
I think they had a great paper published about, I think, the first several months of their use of NAMA, which was, to your point, really insightful for everyone else who hadn't jumped on as quickly. What can, I guess, in your mind, startups learn from this experience? What is the right way, in your mind, for a startup to engage an organization as large as Kaiser? Like, is it typically right to try and work with one of the medical groups, create an internal reference point, and then scale? Or is it actually, no, you should try to go top down the enterprise level so that you have those relationships? So what can startups learn from that?
Yeah, that's a good question, because actually I think I've chatted with some very, very early startups, and they've actually asked me that similar thing. Because most of the time startups say like, oh, can you just introduce me? Like, can you introduce me to someone who will kind of listen to this and, consider it? And I honestly, and obviously I can do that type of stuff now, especially because I have still those connections. But what's interesting now, I think, with this is you have to probably approach it from two ways, especially for these behemoth organizations. Like, I think there is like this, what I call like the grassroots method, where you try and target some of those influential people in the organization, but maybe are kind of lower level. And it sounds derogatory, but like, just a lower level leadership position. And then if you have the ability to tap someone pretty high up, like that can obviously be beneficial too. It's just the people way at the top won't actually really like know about the product and really understand how it like is actually going to help the people on the front lines or the patients necessarily. But then the people on the front lines or the leadership on the front lines, they're going to understand it really well, but then they're going to have to like kind of push upstream. And so like this has happened to me as CMIO. I mean, I would constantly get emails from physicians I worked with, and they'd be like, hey, I just saw this vendor do a demo. It is amazing, And I'd be like, okay, why don't you schedule some time with me? And I want to hear why you think it's amazing, and then I would understand what problem they thought it was solving. Then I would typically go, okay, let me do some diligence on this vendor to see if it's actually something that could work too. Sometimes those folks, they get swayed by the shiny object of the demo, and they don't realize some of these like key kind of components that weren't a part of the demo that actually we probably need as a table stake before we could even consider, using this extra piece. So long-winded way again of your question, but I think the best approach is probably to try to figure out connections and people that can help on both sides, that can get it to the person who's like in charge of that specific, group that would benefit the most from the vendor product. And then also if you can get in with, get the bug in the ear of a higher level executive. I just think in organizations like KP, or even, you think of like Mayo, which is like spread all over the US now. It's like you talk to Mayo in this state, that's different than the Mayo in Rochester versus the Mayo somewhere else. And it's kind of the same in Kaiser. The good thing is, and this may be a selfish thing, but I honestly think CMIOs are one of the best places to try to tap, because they'll know how to go downstream and upstream, depending on whatever their level is. So that's always my go-to for when I'm trying to, engage in that way too.
Yeah, and also I think what I've found is CMIOs uniquely understand both the tech and the clinical side of things, whereas a lot of times they're, let's call it IT leaders who really into cybersecurity but don't have the same perspective on the value of a more clinical technology solution. So I think if you're in the more clinical space, the CMIOs are definitely the folks who get that piece. So in 2023, 2024, Ambient was a very, very hot topic in healthcare IT. Do you have any predictions about, let's say, 2025, 2026? What will we be talking about in this podcast with you instead of some Ambient?
Yeah, that's a good question. I mean, I put out there a fair amount of stuff like where I kind of think medicine is going. And I guess the thing that I'll admit I don't have the timeline for is like, what is that specific timeline? How short is some of this going to be? And then how much of it is going to take a bit longer to reach fruition? I think, though, a couple areas, I guess I'd highlight. Number one, I think there is this like growing kind of starving need for like what direct primary care has kind of like taken out of like, or just kind of surfaced what, patients ideally want, and then what physicians obviously want too, in a patient-physician relationship. So I think that kind of spirit, and the reason why, I mean, some of my close physician colleagues had left a larger organization to join a direct primary care, and vice versa. I just keep hearing more and more people in my community that will be like, oh yeah, we have, Kaiser Insurance or Aetna or whatever, but I have this concierge doc now that I, pay a couple $100 a month for. And I've kind of like picked their brain. I'm like, why do you do that? And it's like, well, it's because I can like get my answers answered, and like I can get, I have this access. Well, the big problem I have with DPC is it's not fixing our problems in healthcare, which is, I mean, it's fixing some of them, like a patient experience and an access problem. Great, good. But it's not fixing things on a big scale. It's actually making it worse, right? It's making our diminishing resource of physicians, especially in the US, but I think worldwide, and a growing population. Like, it's not a good recipe to start being taken care of less. So I think learnings from all that, long-winded, I think there's going to be more solutions that come out that try and tackle that problem, but give patients that same, similar, and doctors that same experience. That's something I'm kind of like focused on trying to fix, so to speak. And then I think along those lines, what's I think really going to emerge, especially in like probably a year timeline, I think I have a lot more confidence in this one, is just more of the precision screening, kind of better screening of different things that we have in healthcare in some novel ways. Like, I mean, I think there's gonna be some technology things that probably come up that are going to be maybe mind blowing, but I think honestly, it's just going to be kind of rethinking ways that we've already traditionally done these things. Because I think, again, people want to be treated like a person and not just like a population, like where when someone goes into the office, it's like, so I turned 45 a couple of years ago. All of a sudden I was supposed to get colon cancer screening, right? But like, why is that my individual risk is like at 45? Like, no, that's the population's risk. And it used to be 50, now it's 45. I think we need to get to a place where there's just this more intense personalization and precision for people, and I think people like Peter Tia and, that kind of movement is kind of pushing that envelope. But I think that type of stuff is going to become more mainstream in the next year or two. That would be probably my most confident prediction.
And I guess like the companies working in that space, I think they've kind of taken, let's call it the Tesla path, which is you make some, very high quality, but probably more expensive direct-to-consumer approach. So like, the full, I'm not saying this is what you're advocating for, but like, the full body scan companies or the, executive medicine sort of approach where, okay, we're going to spend more, it's going to be incredibly personalized. We're going to probably deliver more personalized care. We're going to catch things earlier. It's not necessarily a scalable model for the whole population, but maybe we figure out from there how to make it scalable. That's the one approach some companies I think are taking and trying to tackle that. But do you feel like there's another approach that they should consider, but trying to actually do this in a way that can reach the population and scale faster?
Yeah, super good question. Because I think, all those little things you mentioned, it is, I mean, I would call that Tesla approach too. You're going after a consumer market that can afford these types of things first. But I mean, look at everything in history. I mean, how much were VCRs when I was a kid? I mean, they were over $1,000, right? I mean, now you can't even buy one, so it's a bad example. But, like there's a lot of things like a microwave oven. I mean, when those first came out in the 70s, I mean, those things or 80s, those things were super expensive and they were horrible too. I mean, they were bad. And now it's like, you can buy one at Walmart for $99, So I do think there is something to that like model of like where innovations do start like really expensive and then there's ways to trickle down. But I think to your question, I think there's probably some other ways to do this. And frankly, it's more of those like kind of new approaches, where I guess the way I frame it up is I think, if you just take strictly like why a person would like want to seek help from a physician and then what a physician can help with. And I think on both sides of that equation, I think physicians are seeing way too much stuff that they don't need to see. And I don't mean that disrespectful to any patient, because every patient has a legitimate complaint, but every patient doesn't need to like book an appointment with a doctor to talk about everything. So I think what's going to hopefully happen is there's going to be something that comes along that just, it helps the patient answer their concern better in a new novel way. and allows physicians to actually see the people that they're specifically trained to like make decisions on, you know? So again, I mean, some people may be listening between the lines and going, oh, is he talking about like some sort of AI that's going to replace a doctor? I mean, I'll go out and say it. AI is going to replace what doctors do today, like in the near term. It's not going to ever completely replace, but what it looks like to be a physician today and what it looks like to be in 1, 2, 5, 10 years is going to be totally different. And that is the only way that we can take care of more people and also be able to have a sustainable career as a physician and an enjoyable career by allowing them to really focus on what they're expertly trained to do.
I mean, to your point, I'm certain there were things that physicians were doing 100, 200 years ago that they're just not doing today. And probably back then there were physicians who were worried that, oh my gosh, new technology came about, I'm not going to have a job. It's like, no, like you're right. Your job changed based on the technology that changed and how society had changed. You know, one of the things that comes up often is people saying, hey, you know what, if we can use technology or something else, or even just other people to get rid of the, let's call it simpler tasks physicians are doing, so that physicians can act more at the top of their license, they were going to get more value out of medicine. But then the other side I hear from physicians is like, you know what, sometimes I like the easy stuff because I'm really tired, right? I don't need to be working at the top of my license every single minute of the day. So I'm kind of curious, like, do you have any kind of viewpoint on that? Because I even like, Al, I don't know about you, but for me, it's like, you know, there are some things I do during my day where like, yeah, like maybe someone else could do it, but I kind of like that, you know, I don't have to think so much sometimes.
Totally.
Yeah, no, I agree. I and that is a delicate balance because, yeah, you don't want to create a picture. I think a good example is like orthopedic surgeon, right? Like, you know, an orthopedic surgeon, what do they want to see in the clinic? Like they want to see patients that they can actually do a surgery on that's appropriate and needed, right? They don't want to see the people that have like their knee hurts or their ankle hurts, you know, like it's not that they don't care. And yes, frankly, those would be super easy for an orthopedic surgeon to be like, oh yeah, you know, it's this, that. I mean, they could probably diagnose it really quickly, but it's like, I don't know. I think it goes back to like what you're specifically trained to do. I mean, I think, yeah, so like for an orthopedic surgeon, I think what I said before kind of probably works well. And they actually do that now. I mean, most groups hire, you know, scribes and a lot of like physician assistants to like basically handle all that other stuff. And then they just do the stuff that's going to frankly be the real revenue generators, but also I think the more satisfying things for them too. But I think like, yeah, for more like a primary care physician, yeah, you could argue like you don't want to just do 100% of the hard stuff, like at like a 50x rate of what you're doing right now. Even if AI made all the other stuff go away, that would also be probably pretty mind numbing too. So I guess, yeah, you do have to strike a balance. I'm not sure what that is, you know, but maybe it's just, you know, if you could be so much more efficient actually taking care of enough patients that it does give you more free time to have the offload time to like read a journal article or watch a YouTube video or flip through, you know, LinkedIn and read what people are posting. Like, I think that is what would make things more sustainable. What's not currently is just you show up at clinic and you literally like don't stop until you are done for the day. There's no break.
Yeah, I think part of it too, like I forget who came up with this, but you know, when people get burned out, it's not necessarily because maybe they're being overworked in general, but it could be that they're doing a lot of work that doesn't bring them joy or energy. So I can imagine how, let's say, documentation probably doesn't bring a lot of clinicians joy and energy to be documenting stuff in the EHR. And so it's not that it's necessarily it's complicated. It's just that it doesn't energize them. And then they get burned out because they're doing a bunch of work that takes joy away.
Correct. Yeah, I mean, I would argue like any physician that goes into the profession, I mean, they truly want to help people and they want to use their expertise to help make the right decision, you know, the shared decision, I'd even say that, you know, with the patient. I mean, and again, I mean, not to circle back to this ambient scribe thing now, but it really does. I mean, my new kind of clinical secret gig is, you know, I do some video visits as a part of it with patients, and like being able to have one of these scribes, it's like totally different experience, like being able to just have a conversation with this person via video. You don't have to think about writing something down, or like, you got to miss this, or I got to remember this. I mean, I remember back in the day, someone would tell me something and be like, okay, like I need to mentally like remember, like they had this heart disease thing at this age. And like, that's the type of stuff that just that cognitive load of things is, I think, what actually makes you feel toasted at the end of the day. So when you can offload it with some of these things that just make it easier, even if you're actually doing more work, I think it still makes you feel more refreshed at the end of the day. And I've heard that from a lot of clinicians. I don't know how to measure that, because I don't think there's like a cognitive load index, whatever.
There's something. There's some sort of like set of instruments people are using to measure.
I think there are.
Yeah.
But I just heard from many physicians would say that. They'd write me and say, they're like, I don't know what it is with like using a bridge now, but like, I just, at the end of the day, I don't feel as burnt or like as toasted. They would used to use those terms. And then they would say their spouses at home would notice it too. So I don't know. There's something there that's not like totally objectively tangible yet, which I think needs to be teased out more.
Right. It's also neat how that is the characteristic of what you envisioned for the future of medicine when you first joined. I've heard you talk in the past about the idea of, when I go into the room with the patient, I want to just look at the patient and start the conversation. I don't want to have to log on to the EHR and set up my notes and all that and go through all the history. So I think it's really cool that, this is potentially becoming more and more real as we go through the days. I had one last question for you, Adam. You recently shared an equation online, and I think it was half joking, but I know you were serious in that as well. And it was NT plus OO equals COO, or new tech plus old organization equals a costly old organization. And so I wonder, can you unpack that idea for us and maybe share some of the common pitfalls that you've seen old organizations fall into when they're implementing these new technologies?
Yeah, I think, yes, and you were right. I did do that as like a little bit of like a comedy, but it actually is very baked in with truth. I think what happens with this happens across all industries, outside of healthcare too. I think just, companies will get comfortable in their ways, or they'll have created something that they think is really good. Like, didn't Slack actually start with like an internal tool for like the company that made it? I think it was
like they were making a video game, and then that wasn't really working. By chance, they made a communications tool, and they spun it out as Slack instead.
And they're like, oh my God, this is so helpful. Like, this should be like made available to everyone. So I think it's like that. It's like there's times where companies will make something, and I think this is just somewhere where, healthcare companies that have been around for a while have fallen into this trap. They've created something, and they just like they put so much humans behind it, and there's like kind of this like spirit behind it, that anything that comes along that's honestly better, like frankly better, they won't see it that way. They'll be like, no, that's not, what we do is better. And I've personally seen that happen many, many times. And I think a lot of people in large health systems see that. And so that's what that was kind of getting at, was that it just, it's not going to be as easy as, for instance, if there's a vendor that just easily plugs into like a native EMR. That works great if that organization has a very vanilla native EMR. Like, if they've put a lot of layers of customization or other things into it, it's not going to be easy. It's going to be more costly. So I think that's why that equation resonated with me, is because I just seen some of those examples where things come along and the vendor will be like, this is so easy. It should only take like 2 hours to implement. And you're like, well, times 10 to that, because we have this process and these things. I'm sure you guys have experienced this.
Well, in a weird way, like all that friction that exists in getting new tech brought into organizations. I mean, as a CMIO, maybe you kind of like that, because that way anything that isn't really critical to implement, or it doesn't really align with the priority, just can't get in because there's so many layers of bureaucracy. Like maybe you like that as a CMIO sometimes.
Yeah, sometimes that is like something it makes it pretty easy, because you can just be like, yeah, this is great, but there's no way that we're going to be able to, get this through the 17 layers that it would need to bring to fruition. So yeah, sometimes it did make decisions really easily. And I always told people, like, on my team, they'd be like, why do you take so many of these meetings for these vendor products? And I'm like, well, because they look potentially helpful,
Yeah.
but usually within the first like 5 minutes of the meeting, I could tell like this is going somewhere, this is not going somewhere, like just in the framework that I worked in. And it wasn't necessarily because the product was bad or whatever. It was just there would be something about it where I'd be like, oh, this is going to be an uphill battle, to like try and get this in. There's going to be some sort of person that's going to say, we can't do that, for a variety of reasons. But yeah, I think kind of circling back to your question, Alan, about the equation, I think the reality is, I think just big healthcare organizations, they need to be more adaptable and more flexible. And they need to be willing to give up something that they built for 20 years, when there's something now that they can just plug in and it'll be better. That's what I meant by that.
Totally. Yeah. Makes a lot of sense. Well, Adam, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. We like to end the show with this 5 rapid fire questions for you. First question we have is, what is your favorite book or book you've gifted the most?
Yeah. So, I mean, whenever people ask me what my favorite book is, it's usually the one that I'm currently reading. It's like the most fresh. I mean, there's been a lot of good books. I mean, I'm not a prolific reader, but I do like reading kind of tactical ones. But I'm really bad at the titles too. So I'm going to open up my Kindle app real quick. So this is not going with your Fast 5, but because I have to wait for it to.
Well, just wait until we edit the episode.
Exactly. You just trim that piece out. The Heart of Innovation is what I'm reading right now. And the subtitle is A Field Guide. It's real small. A Field Guide to Navigating to Authentic Demand. And I just love it because it's kind of about a product market fit, kind of like innovation kind of spin, but they're kind of saying, don't go after it that way. Go after it to create something that creates this authentic demand for whatever customer it is that's going to be using your product. And I think if you seek that, it just seems like there could be a lot higher rate of success.
Question 2, who is a person either dead or alive who you'd love to meet?
That's a good question. I would honestly phrase I've shared this before, and I actually shared about my grandfather in the beginning. I wish he was still alive, because I think for him to see what is going on right now in the world with technology, I mean, it would blow him away. He was in oil and gas and, worked for Standard Oil, which then became Chevron, when they got broken up way back in the day. But I think he would be blown away by these electric vehicles, even though it would probably go fundamentally against everything that he did his whole career. I just wish I could have a conversation and who he am.
Yeah, that's awesome. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
That seems like that would be conditional, but I guess probably the mind reading part, as long as there was a way for me to be able to turn it off.
Right.
Sometimes.
Yeah. Awesome. Question 4, what is something in healthcare you believe that others might find insane?
I think if people truly understood how complicated much of it is, I think some people from the outside of healthcare have this very simplistic, look at just how the whole machine works, from seeing someone to billing to claims processing, just all of that. It is, trust me, it needs to be fixed, but I think people would be blown away if there was some sort of big expose on what that actually is in a very cool documentary.
Yeah. Yeah, it would have to be a 20-part series, at least an hour each episode. So it is insane. The last question that we have, Adam, what is the last film or TV show you saw and what did you think of it?
Well, I mean, so this again, my wife and I watch, we sometimes will get into some of the series, on Apple TV or Hulu or whatever. But I think, so most recently we finished watching the 2nd season of Loot, which is hilarious. It's if you like Ted Lasso, I think Loot is it's kind of written in the same way. It's not the same story by any means, but very funny. Characters are great. Highly recommend that. And then I think the other thing, my youngest, who's about to turn 11, finally has the courage to watch Stranger Things now. So we're all watching Stranger Things again. So very fun to watch that, the second time or the third time, however many times it's been.
Oh, that's awesome. Well, Adam, that is unfortunately a wrap for this episode of The Digital Patient, hosted by CMO MD. I just want to thank you for coming on the show. It was so refreshing to have you on, and We could probably, like, we got through, just for the listeners out there, we got through maybe 2 out of all of our questions of 100 that we had. So we definitely will have to have you back on. There's so much more that we can talk about with you. But anyways, you can follow Adam online on all the social medias. And if you like the podcast, you want to learn more, visit www.cmus.md. Adam, again, thank you so much for spending the hour with us.
Yeah, thank you both. Great conversation. Have a good day.